Hello, my name is David Desilets. I'm a member of the GIE editorial board, and I'm here today to interview Dr. Barham Abu Dayyeh from the Mayo Clinic in Rochester, Minnesota, and we're going to talk about his paper entitled Large Caliber Metal Stents versus Plastic Stents for the Management of Pancreatic Walled-Off Necrosis. So, Dr. Abu Dayyeh, thank you for coming.
Thank you, David, for the opportunity.
So this is a great paper. I love this paper, and the reason I like it is because it shows a high success rate, and it also shows a lot of the problems that I have when I drain these things. And so I'm going to ask you a few questions, some about methodology, some about outcomes and that sort of thing.
Absolutely.
So I did note when I was reading it, it was not a randomized trial, it's a retrospective trial. And so, you know, that might be a criticism. Did you get any criticism from the reviewers about that, and how did you address that?
Absolutely, David. As you know, the nature of this field, it's very hard for one center to have enough volume, and usually you need multiple centers to do a randomized trial of this number that usually will take a few years. The advantage over other published study within this field is usually, if you look at the literature right now, looking at management of walled-off necrosis, it comes from multiple centers. As you know, the big criticism here is the approach has been heterogeneous. Some people do debridement, some people do drainage, how do you debris, how many times, it's all heterogeneous. The good thing about our program is we all have uniform approach to walled-off necrosis. That means it was a good time to look at our experience when we were using plastic stents versus when practice changed and we were using metal stents. So it became, in a sense, a natural progression of a center that does the same thing, managing the walled-off necrosis. So that's, I mean, I agree with you, it's retrospective, but I think the heterogeneity is limited based on the single center design of the study.
Right, I agree with that. I mean, I believe that the fact that it's sequential versus you're not doing the double pigtail stents and the fully coated metal stents at the same time and cherry picking patients for each one. Rather, they were all double pigtails and then they were all fully coated metal stents. And so you would have to assume that, although one's a more historical population than the other, that they would be similar.
Correct.
I'm curious, I have a few questions on your methodology. How long did you treat with antibiotics for these patients?
So usually the protocol is everybody gets antibiotic at baseline and they continue it until for 2 weeks unless there's some resistant organism that's grown. So 2 weeks from the date of the first initial drainage procedure.
Okay. And then you would re-image them at what, 6 weeks?
So our protocol is if you're inpatient, you get re-imaged with a CT scan or MRI at a week to determine if you need further necrosectomy. If you're outpatient, every 2 weeks. And you continue until the collection has resolved, and then you remove the stents. If there's disconnected duct, you put a pigtail to manage the disconnected duct, or you send the patient for referral for surgery if that's the indication.
One of the things I noticed in your paper, and correct me if I'm wrong, is there was no difference in infectious complications between the metal expandable stents and the double pigtail stents. In my own practice, I never seem to have infection when I use double pigtail stents, and when I switched to the Axios stent, I noticed that they would sometimes get clogged with bits of necrosis, and I would get infection long after the 2-week antibiotic interval was done, and I would have to bring them back in and unclog them and put them back on antibiotics. You guys didn't see that. What do you do differently?
That's great points. So the strategy here that we follow is the strategy of large caliber drainage in order to allow for gastric juices to go into the collection and do some of the necrosectomy between the necrosectomy sessions. So that's the whole hypothesis here. However, there's a limitation, and you've known that these collections are very heterogeneous. There could be a large amount of solid debris. It could be mushy. It could be very solid in consistency that could plug these stents. So our approach has been, we put a large caliber metal stent. At the index drainage procedure, we go in there and start breaking stuff out. So we break as much as we can with snares and with hydrogen peroxide, lavage, and with irrigation. And then we don't pursue a long necrosectomy effort at this session. We just break things so things could pass easily. And I think that's what we're doing different. And that's what you're going to find, that a lot of the heterogeneity that's in the literature is how people approach it. Some people drain it at one site versus multiple sites. And some people do some necrosectomy. Some people don't do any necrosectomy. And I think that's the differences that we're seeing between these results.
So you actually hit on several questions that I have written down. So one of my questions was, most of these patients, when we see them, they were inpatients, they were pretty sick, they're all on PPIs. Do you stop their PPIs to let the acid rebound and help you with your, necrosis liquefaction?
Excellent question. Depending on the setting, if the patient's critically ill in the ICU and now there's a risk of aspiration or stress ulcers from stopping anti-acid therapy, we don't. But if the patient is well up and an outpatient setting, we try to stop the PPI.
So it's
individualized to the patient. That's correct.
So the hydrogen peroxide thing, I've been reluctant to do. I've done some looking. There are theories out there about peroxide metabolism being involved in ulcerative colitis pathogenesis, and there are many case reports of patients, usually women, interestingly enough, but case reports of patients who gave themselves peroxide enemas and got terrible colitis that looked like ulcerative colitis. So I've been very reluctant to use hydrogen peroxide. Your paper says dilute hydrogen peroxide. Do you take the 3% right out of the bottle because that's dilute, or do you dilute that further?
Oh, we take the 3% and dilute it by 3 folds. So 1/3 peroxide.
So it's 1%.
It's 1%.
So it's 1%. And how much do you use?
We put it in the irrigation jet, and as I told you, the first index procedure, we're going there, and the task is to break things down rather than to remove them. We'll let the stent do the removing later on. So we put it usually, it's end up in a 500 cc's, and we just irrigate with the 500 cc's.
Okay. All right.
But good point, not in this series, but I observed this phenomenon recently in an undiscovered fistula between this collection and the colon. We used hydrogen peroxide, and she developed hematochezia. You looked at the colon, and you have to assume that's this colitis induced from the hydrogen peroxide. So there you go.
That's very interesting. Wow, that's very interesting. Okay. All right. I have basically one final question that I'd like to ask you is, if you would tell our viewers here, what do you think, if you could take one take-home message from your paper, what is the one take-home message from your paper that you would like to convey to our audience?
The one take-home message is we're dealing with a rare disorder, relatively rare or relatively encountered only in academic medical centers, and our approach to it has been very heterogeneous. We know that the endoscopic approach is superior to more invasive surgical approach, that's established, but we don't know what's the most optimal and cost-effective endoscopic approach. We are in the era where we're accountable to what we spend, and we're accountable to how many endoscopies could we do. So the big take-home message is using a large caliber drainage paradigm allows us to achieve good success rate with less procedures. So the take-home message is we save the patient on average 1 endoscopy by using a large caliber metal stent versus using the plastic stents. And I think the phenomena here is in between the scheduled necrosectomies, there is auto necrosectomies being done by the body itself that's excreted in the intervals between the procedures.
Well, you certainly save them surgery as well. So, all right. Well, thank you, Dr.
Absolutely,
Abu
it's my
Dayyeh.
pleasure.
Thank you very
Thank
much.
you so much.
I appreciate it.
Absolutely.
Thank you.